Good afternoon, everyone. We're going to give it just another 30 seconds or so before we get started. We still have a few people joining as we speak.
Good afternoon, everyone. Thank you for joining. Today's topic is from burnout to balance. We're just kind of giving it just a few more seconds as people are still hopping on attending this call. So just hang in there and we'll go ahead and start very soon.
All right. Well, good afternoon. Welcome. I'm excited to have you all here. We are going to go ahead and get kicked off. Welcome to Burnout to Balance, the impact of speech therapy, occupational therapy, and physical therapy tools on empowering caregivers. My name is Kylie Ofterheide. I'm a physical therapist, and I'm a regional clinical director with Aegis Therapies.
My name is Alka Mehra. I'm an occupational therapist by background, and I'm also a regional clinical director with Aegis.
I'm Nikki Willman. I'm a speech therapist. I'm currently a staff therapist with Aegis, also having been a DOR and a TC in the past.
We're going to go ahead and just cover a few housekeeping items before we jump into content. So for some of you, this may be new. Others might be a little bit of a review, but all lines will be on mute throughout the presentation. So we'll ask that you use the chat feature for any questions that might arise during the presentation or after. If you are joining with another team member, if you could please just put your name in the chat. Shyla is our moderator, and then she'll be able to have your email to send out course certificates after we are complete. So certificates will be sent out automatically, usually within 1 to 2 weeks of the completion today. And we have about an hour-long time slot planned, and we will hang out for questions following the presentation as well.
OTs are required to pass the post-test quiz within a week for the credit, and that will be emailed after the webinar. Again, Shyla is our go-to person, so if you have any questions, please reach out to her. Her email is right there, or you can also reach out in the chat as well. Again, 1 to 2 weeks for the certificates to be sent out. Again, the chat feature on the control panel on the side will help. At the conclusion of the course, we expect that you'll be able to identify characteristics of caregiver burnout, be able to analyze the health literacy of a caregiver and explain the role of therapists in educating caregivers about the disease process, be able to implement some of the interventions and action steps to support the caregivers based on the care setting, and be able to accurately explain the proper billing and documentation for caregiver education.
All right, thank you, Nikki. So we're going to go ahead and just jump right in here with defining caregiver burnout. Caregiver burnout is a state of physical, emotional, and mental exhaustion that caregivers can experience as a result of the prolonged and sometimes overwhelming stress that is associated with caring for another person. It often occurs when caregivers potentially neglect their own needs while focusing on the needs of the person they are caring for, which can really lead to a depletion of energy, motivation, and overall well-being. We can see signs of physical exhaustion, whether that be chronic fatigue, sleep disturbances, maybe physical ailments such as headaches or digestive issues. It could be emotional exhaustion, feelings of helplessness, hopelessness, being overwhelmed. Caregivers may experience irritability, anxiety, or depression. Mental fatigue, potentially difficulty with concentrating, forgetfulness, reduced ability to make decisions or problem solve. A withdrawal from family and friends. There could be a tendency to pull back from social activities, which further isolates caregivers. A loss of interest, so diminished interest in activities that the individual might previously have enjoyed, such as hobbies, work, or other aspects of life outside of caregiving. Potentially neglecting personal needs, ignoring one's own health, hygiene, nutrition, and emotional well-being, just due to the demands of caregiving. There potentially could be a decline in care quality seen. The quality of care might decline as the caregiver becomes increasingly burnt out. That could potentially lead to mistakes, neglect, or just impatience with the care recipient. So next we'll talk about some assessment tools. So how can we define caregiver burnout? And that starts with our skilled observation. Assessing caregiver burnout can be done using a variety of objective measures as well. Some of them are standardized questionnaires and scales that are designed to really evaluate the emotional, physical, and/or mental state of caregivers. And some are more specific and are measuring one key area. We have some of these tools listed here. This is not an exhaustive list, but a few assessments that really could be helpful in identifying caregiver needs. These are all free assessments that are available online, and a few of them are in the resources or the handouts, excuse me, that are available to be downloaded as well. To name a few, the Patient Health Questionnaire, better known as the PHQ-9, Geriatric Depression Scale, Hamilton Anxiety Rating Index, Caregiver Self-Assessment Questionnaire, and the Beck's Depression Inventory. I wanted to highlight just one of the assessments. The Caregiver Self-Assessment Questionnaire is a tool that was developed by the American Medical Association, or the AMA, to help caregivers evaluate their own level of stress, burden, and potential burnout. So this is a self-report measure, and it really allows caregivers the opportunity to reflect on their caregiving experience and potentially identify areas where they might need additional support or even more formal intervention. So the questionnaire is designed to be a quick and accessible way for caregivers to recognize the impact of caregiving potentially on their own health and well-being. They respond to each question based upon their recent experiences. And the total score or pattern of responses can really be indicative of the level of stress or burden that the caregiver is experiencing. Higher scores generally suggest greater stress and the potential for burnout, indicating the need for additional support or intervention. All right, so we are going to jump into our first polling question of the day. What is the number of informal caregivers in the United States? A, 1 in every 25 Americans. B, 1 in every 5 Americans. C, 1 in every 10 Americans. And I'll give it a minute here for y'all to respond and then Shiloh will kind of let me know when we have most of the responses in.
All right, it looks like most everyone has answered, so I'll go ahead and close it. And 23% said 1 in every 25 Americans, 30% said 1 in every 5 Americans, and 47% said 1 in every 10 Americans.
All right, thank you, Shyla. So I think this is just a really good kickoff to understanding how prevalent this topic really is. So the answer is B, 1 in every 5 Americans. So currently in the United States, there are approximately 53 million informal caregivers. So I think this is just a really great opportunity for us to discuss the different types of caregivers, burnout, and then the strategies that we can help to empower caregivers. That kind of brings us into our next slide here, in really understanding caregiver roles. There isn't a one-size-fits-all, right? We have paid and unpaid caregivers, and both really provide essential care and support to individuals who need assistance due to a variety of reasons: age, illness, disability, other health-related conditions, and comorbidities. However, there are some important both similarities, but then differences between these two groups to highlight. They both will experience or can experience physical and emotional strain, stress, fatigue. Both are at risk for burnout due to the demands of caregiving. We'll kind of go into paid caregivers first. So there are many more paid caregivers than we can certainly list here, but typically we're going to think of our healthcare worker, a nurse, us on this call, therapists, CNAs, physicians, psychologists, social workers. And for these paid caregivers, we really wanted to highlight some of the things that we might see or feel if we anticipate that there is caregiver burnout that is occurring. You may see a colleague calling in more frequently, potentially arriving late for work or for a shift. Maybe just an overall flat affect and withdrawn, leaving early, potentially postponing assignments and tasks, an overall sense of negativity. For unpaid caregivers, these are caregivers who are informal, right, and not professionally trained. Oftentimes, it's a role that is very emotionally linked and that they inherited. So certainly could be a spouse, a family member, a friend, or a loved one. And the time commitment is typically quite burdensome. Oftentimes, it could be a 24/7 role, right? These caregivers may feel secluded or isolated. They might experience sleep deprivation. They feel withdrawn from other components of their life. There could be a negative financial impact as they have needed to step away from an occupation potentially to really step into this caregiver role. And oftentimes there could be signs of neglecting physical or mental well-being. All right, Elka, I'll turn it over to you next.
All right, thank you, Kylie. So this is a good place for us to kind of move into what kind of things we can do to provide that caregiver support. We'll go over a few resources and strategies that are going to help support caregivers. So empower caregivers. How can we help them understand their physical and mental well-being? Uplifting caregivers through education, advocacy, support, while also recognizing their invaluable role in society. Empowering caregivers is to improve quality of life, not just for the caregivers, but for their loved ones as well. Are they asking and accepting help? That is one of the hardest things for all of us to kind of do, is ask, or if someone is offering help, to accept that help. One of the other component is health literacy. Health literacy is the degree to which individuals have the ability to find, understand, and use the information and services for both health-related decisions as well as actions for themselves and others. The other important component is that tailored education. And by that, we mean providing specific training, specific education based on the needs, environment, living condition, and specifics to meet the caregiver needs. PT, OT, speech therapist, how can we assess and recommend appropriately? As we go more into the PowerPoint, we'll be addressing some of these components a little bit at a deeper level. And now when OT, PT, and speech are assessing and providing the recommendations, we also have the ability to recognize and then make referrals as we deem appropriate. That referral could be to a physician, to a psychologist, maybe a social worker, or thinking about support groups. When we are recommending these services, we remind our caregivers about respite care, community resources, adult day program, religious and spiritual support. All of these are just a few things that we can think about in terms of how we can empower our caregivers with different resources and strategies. Since I'm an occupational therapist, I'm going to talk about some of the things that we as occupational therapists can consider and make recommendations. Kylie touched base on some of these assessment tools at the beginning of this presentation. I just feel like skilled observation is one of the unique skill set that we as clinicians have. We always are kind of playing little detectives. We are observing for facial expressions, appearance, attention span, concentration, posture, response to the responsiveness to questions, and that's how we assess and analyze a person's well-being, whether it's at the physical level or at the mental level. Then we kind of go into that one-on-one conversation and discussion to really find out what is going on. We utilize so many different assessment tools, and then based on those assessment tools, the outcomes, scores, interpretations, we figure out the goals and appropriate recommendations. Kylie had kind of touched base on a lot of these. Again, just remember, this is a very small list. We just wanted to highlight some of the resources. I in particularly like the PHQ, or the Patient Health Questionnaire, because that truly talks about some of the things that we may be encountering or experiencing within the last 2 weeks. I know when I go to see my medical care provider, she always has me fill this PHQ form that really talks about, some of the questions would be little interest or pleasure in doing things. Have I experienced a decline within the last 2 weeks in any of these components? Am I feeling down, depressed, or not feeling well? Is there a change in my happiness? Feeling tired or having little energy? So those are some of the questions, and it kind of gives you an aggregate score as to where things are going and what we can do to mitigate some of those symptoms that a person may be encountering. And then the next slide kind of continues to talk about training caregivers. Educating on strategies for physical and mental well-being is the most important thing we can talk about. Pain management is the caregiver going through, some kind of a pain, and they are maybe neglecting or ignoring that because they are so busy caring for their loved ones. Making appropriate changes to environment, which will in result improve the safety and efficiency of that environment. Instructing use of adaptive equipment and adaptive devices. Energy conservation techniques, for example, pacing, alternating heavier or lighter tasks, maintaining sleep pattern, just for the overall, consideration of finding out what seems to be relaxing for me. So we kind of talk about some of the relaxation strategies. For example, watching a favorite TV show or movie, listening to music of choice, and some of the other things are yoga, deep breathing, that kind of a thing, which we can continue to educate and coach our caregivers to consider as we are training them. Over to you, Nikki.
All right, and so with the training of caregivers, and the caregivers can be the family members that we talked about, paid or unpaid, could be children, could be extended family, could be neighbors. It also could be your coworker, and it can also be the people that you work with, social services, CNAs, nursing staff, all kinds of different people. In my experience, we were talking before about how we are therapists for so long, and a lot of things that we do are second nature. And we kind of think, well, why don't you know this? Or how come, you're not just doing this by yourself? And we have to take the time to realize that not everybody is as knowledgeable as us, or always just thinks that's the, common knowledge. So training staff people and family members on mobility and safety techniques, things like body mechanics, knowing how to properly transfer their loved one, maybe using a gait belt. We've sent people home from the SNF environment with sit-to-stands, Hoyer lifts, things like that. People who are sometimes coming into the healthcare system for the first time, whether it be taking a family member to, an outpatient visit, status post-surgery, or being in a SNF after surgery, they're not aware of all the equipment and all the things that exist. They're not sure how things work. They don't know how to transfer people. They don't know how to prevent their loved one from being hurt or from hurting themselves. As we find out, and I was telling the team about a patient who was celebrating her 110th birthday, and knowing that her kids are going to be in their, in their 80s, or so it could possibly be an older person helping yet another older person. So you kind of have to look at both people as well, the caregiver and the resident or the patient. So body mechanics are important, teaching them how to do safe transfers, different environments in their homes, couches, things that you don't even think of, like having chairs with arms, just some of the basic stuff that we think, well, of course he can't get up, he has no quad strength. So you have to think about those little things that we go like, of course, but the common person doesn't really think about those kind of things. So taking all your knowledge and using some of the stuff that we do day to day is a huge help for some of the caregivers. They're like, oh, that's a great way to do it, or oh, that's so much easier, or I'm not going to hurt my back doing that. Some of the things you can do to help relieve that burden for people is give them the information on fall prevention, how to clean people's environments when they're going home, if that's going to be their discharge location, things like cleaning clutter, putting down rugs, removing extra, barriers, those kind of things, keeping clean pathways. I know that Aegis, as well as, some of the handouts from AOTA or APTA, have a lot of kind of information on that and checklists to help family members as well. Balance training and education, teaching family members and even staff members just ways to maneuver, showing them to keep things maybe within reach so people don't have to reach out of their base of support. Those kind of things that you don't even really think of, like, oh, of course you want to put this on this side where they can reach it, or make it a little bit easier for them to access this space. And you're thinking about where that person is going to be discharged, whether it's to maybe a SNF long-term or a CCRC or back to their community. Community mobility is a huge thing. Mom's home now, but what are we going to do to keep her safe, and how is she going to get to her appointments? How are they going to, we always set up a primary care physician, and then they have outpatient, they have follow-up with their ortho. People work. It's hard to have family members do these kind of things. Look for your community. A lot of senior centers, councils on aging, they will have ride programs to pick up people to bring them back and forth to appointments. They have community equipment sharing programs in Massachusetts. I don't know if you're part of the country where you are. We have a lending program where people can donate equipment, walkers, wheelchairs, things like that. Maybe they only need them for short term. We have Hoyer lifts and hospital beds available for use for free for people as well, to make those kind of things an easier transition back into the community for mobility. Pain management, as Alka touched on, huge, to make sure that their loved one is, in the best shape possible, to make it easier to care for them, make it easier on the entire system as well. There are a lot of clinics in different ways, outside the box of thinking for people, and that can kind of be adapted together. Things like, yoga, stretching, some of that stuff that your therapist might be teaching you in your, home exercise program can kind of fall into managing some of the pain and things like that. Again, promoting health and wellness, the HEPs, the safe and prescriptive exercise programs that can kind of be like a front loading and keeping the strength and the gains that they've made, either status post surgery, or if they're going back to their community, you don't want them to stop walking, stop doing all the wonderful things that they've done. So, and that can be teaching the CNAs through a functional maintenance program. That can be teaching the resident themselves through a home exercise program. That could be following up with your senior centers, or even the disease-specific kind of classes. I know there's a lot of support groups for Parkinson's, Alzheimer's, there's LSVT groups. There's a lot of different resources in your community as well that can tailor those exercise programs to different people's levels as well. The environmental modifications, well, that's just our wheelhouse, isn't it? Just changing things around, making it easier to move around. How many of us were talking the other day about, moving into a house, making sure the handles weren't turning and that they would push down and do all that kind of stuff, and stairs and what kind of rise you'd have, and just different things you can do to make it as easy as possible for both you and your loved one. And again, the assistive device prescription is making sure that they have the right equipment for what they need to be able to do. And again, through speech, what I have found has been very helpful in a lot of the training of caregivers is letting them know what level their loved one is at. A lot of times you'll have maybe, daughters or, nieces or nephews calling in, hey, how are you doing, Mom? Did you have breakfast? What was going on? How's your day? Those kind of little, interactions, those one-to-one questions are kind of an easy way for them to communicate. Sometimes caregivers and family are oblivious, we kind of think, or don't see the nuances that we do, especially when they're coming into a clinic, or going to their PCP, going to an outpatient PT appointment, or coming into a SNF. And we kind of do our resources. If they've had a medical issue that has caused them to decline from their baseline, they go to the hospital, then they come to us. They're not necessarily the same mom that they had 3 weeks ago. And people have gone through those 3 weeks thinking that their loved one may have had some serious issues, not knowing what was going to happen. So they're on the high level of stress as it is. So being able to help them navigate what's going to be happening has been a huge help for a lot of people. They don't really realize what level people are at. So some of the cognitive assessments that we've used in our clinic are the ACL, the Allen Cognitive Levels. That's particularly wonderful, not only for caregivers, but for also your colleagues. I've seen a few new PTs struggle, and I have to kind of go, hey, they're never going to learn to use that walker. And it's going, or hey, that's why they keep tripping, because they can't see that far. So things that, again, we take for granted, knowing how certain, perhaps dementia or, new onset CVAs or things progress, that we know those kind of things. And so to be able to help your fellow person not be frustrated and keep, doing the same thing with, no different outcome, collaborate, give that education. Let's see what we can do together. The Montreal Cognitive Assessment, the MOCA, is a very popular one too that people use. So more of the dementia ones are the ABCD and the FLCI. The ABCD is for a little bit higher level dementia, and the FLCI is for a little bit lower. So giving the caregivers an idea of, hey, these are what they're really good at. You know, they can match stuff. They're great at puzzles. The visual stuff is still good. Hey, they can't do these kind of things, so you're going to need a little bit of help with that, or this could be a potential problem. So hopefully we can, you know, provide some education, release the burden of them not knowing, you know, what to expect in the home. Again, that, you know, education on the abilities and the expected progression. End of life planning for us caregivers is particularly tough. I know when I had my first resident pass away, I cried with her, and she was consoling me. She's like, honey, I'm ready. And I go, no, it's not. And so going through all that, and as, you know, a newer grad, and, you know, still you find those people that, you know, really hit your heart, and you feel the stress and burden of it, and knowing that they're going through that, and they're not even your family member, they're your work family kind of, but so, you know, being able to provide people with that kind of information on, you know, what their options are for feeding, positioning, care and comfort, hospice kind of things, all of those people and all of those services can be a huge benefit to the caregivers. You know, providing information on following, you know, compensatory strategies. Food is love. It's one of the last things they have a lot of the times, you know, in a SNF situation. So, and it's part of your community, part of your culture, part of everything. You have a birthday party, you have cake. You know, it's summertime, we have picnics. Saying no to a hot dog for someone is very hard. And so we try to give them all those quality of life things. So teaching the family members or the CNAs how to maximize their safety while still having a great quality of life, huge being able to help that kind of stuff. So diet texture modifications, being able to modify things, teaching families how to puree meals at home, what they can provide that's already a softer texture, how are they going to thicken liquids at home, doing those kind of things, providing education and things. And they also have now delivery services. It's not just a Meals on Wheels, they can do modified textures as well. So that's fabulous. And through when you're really having a bad day for both caregiver and perhaps the person you're working with, relaxation and deep breathing, the pursed lip breathing, the recovery, just take a deep breath. It's great for the resident, it's great for the caregiver. And finding those support groups when you are really kind of feeling like you're alone out there. A lot of people are struggling with not knowing what to expect or how to navigate things. Having someone else who's gone through that is a wonderful support. Again, looking at your council of aging, your senior centers, reaching out through your PCP, your own doctor or your loved one's doctor to find some of those services can be a wonderful help as well.
Awesome. Thanks, Nikki. So next we're going to jump into care environments. So really understanding that the environment that we are working in can have such an impact on our residents and caregivers, right? So we need to be able to understand across that continuum of care how we can tailor our interventions. So caregivers within home health, outpatient, and the skilled nursing facility share a lot of common goals to providing care and support with individuals that have a variety of health needs. However, the nature of their work is different just because of the environment that they operate in. So then that means that the challenges they face can vary significantly. So we'll just have a little bit of an overview here on some of the similarities and differences among caregivers in these settings. So we'll start with home health. So caregivers may face challenges related to working in a little bit more unstructured environment, right? So thinking about having to be that healthcare coordinator, and you might be the only care provider seeing this resident that day or for the next couple days potentially, maybe even longer. How do you empower caregivers to recognize red flags? Dealing with potentially inadequate environment setup, how we can modify through those. So whether it be inadequate home setups, social isolation, difficulty accessing supplies or equipment, and really having the therapist be just to excel at their communication to make sure that the resident is getting the needs that they have to be successful in that environment. Moving on to outpatient. Really, when I think of caregiving in this setting, I really think of what first comes to mind is a patient advocate. So really being that individual who's advocating for that resident, whether it be community resources, other caregiver referrals, the support groups, really knowing what can be accessible and available to them. So caregivers here might have a less direct involvement with items that we typically think of, like personal care tasks, but they're going to have a really strong involvement in therapeutic interventions. So making sure that we are spot on with our home exercise program and that effectiveness to be successful when they leave the outpatient setting. And then lastly, the skilled nursing facility. So residents here are often very medically complex, right? They have chronic illnesses, and caregivers may face high patient to staff ratios. This could lead to increased workload and stress. They may experience heavier physical demands upon the body. So really working through body mechanics training, safety, being able to teach and have that reproduced, it will be key in carryover. And then really thinking about documentation and communication for consistency, knowing that we have multiple caregivers and a large patient caseload across different shifts throughout the day. How can we create a consistent mode of communication? Okay, we're going to jump into the next polling question. So, how confident are you in your ability to assess and improve the health literacy of the caregivers that you work with? A, very confident. B, somewhat confident. C, neutral. D, somewhat unsure. And E, very unsure. I'll give everyone here a minute to kind of process through and answer this one. And when we're complete or have most of the responses in, Shiloh will go ahead and kind of let us know where we're sitting.
All right, we'll go ahead and close it. 33% said very confident, 53% said somewhat confident, 9% were neutral, 5% were somewhat unsure, and 1% very unsure.
Okay, thank you, Shyla. So certainly the goal here by the end of our presentation is really anyone that rated themselves, somewhat confident through very unsure, that you would be able to bump that up to a confident level. So we'll jump right into health literacy. Elka touched on this a little bit already, but health literacy is so crucial because it directly impacts an individual's ability to manage their health, interact with their healthcare system effectively. Low health literacy can lead to misunderstandings about medical instructions, poor health outcomes, higher rates of hospitalization or rehospitalization, and overall increased healthcare costs. Enhancing health literacy really involves a few key areas, and that is really providing simplified communication, clear and accessible information, and supporting patients in becoming more informed and proactive in their own healthcare. A few ways to really understand where an individual's health literacy is at is to use an objective tool to help measure it. There's a few listed here. One of them is the newest vital sign. That is an assessment that consists of a single nutrition label, similar to what you'd find on a food package. And patients are asked 6 questions related to that label, which really tests their ability to interpret and use the information that is contained on that label. It might help us identify patients who need additional support to understand health information, such as modified explanations, visual aids, so multimodal communication, and potentially more time for discussion and questions. Another option is the short assessment of health literacy. That is a good practical tool for healthcare providers to assess health literacy quickly and effectively. And then again, it allows adjustment of communication, educational strategies to really meet the resident where they are. The nice option about this assessment is that it's available in both English and Spanish versions. Lastly, to highlight the health literacy questionnaire, this is a 44-item assessment, and it has 9 different domains. So it's a more comprehensive tool designed to measure various aspects of health literacy. So it's definitely more robust. It's going to take longer time to administer, but has a multi-dimensional approach to the assessment. Again, these are just a few options that are available, not an exhaustive list, and they are all free and available online as well. All right, Nikki, I'll turn it back to you.
All right, so now that we've kind of gone through who are the caregivers and what are the signs and symptoms, what are we going to do for our goals? So we're looking at caregiver training consideration for setting goals. So for people like care extenders that we have, again, not an exhaustive list, we're looking at home health aides, the unskilled support worker, transportation support, community volunteers, the senior center people. So those are people that are going to need certain training and information as well. Sometimes it's possible to involve them depending on the setting. Typically, you're working a lot more with the families in a SNF setting, caregivers, the direct families, and those day-to-day people when they're at appointments as well. If you happen to be in a SNF or maybe an outpatient clinic, moving from skilled care to unskilled care. A huge thing we talk about is doing caregiver training from day 1 of L. Always including the caregivers and the residents and the nurses and the CNAs, involving them before we end up transitioning to the next level of care, either just custodial level care at the SNF or going back to their home or a CCRC or assisted living or independently. What you'd like to do, I always try to either use, we have a ton of different forms of Aegis or for the facility, having an in-service sheet, writing down things. Some people, again, we have to take into account different types of learning for everyone. Some people are visual learners, some people are, the return demonstration is a huge piece too. Having the CNAs show you how to transfer someone or show you how to feed someone safely. All of those kind of things are huge because people, you'd like to think that they were able to do those things and do them well. Again, having that return demonstration gives a little bit of ownership and shows that there's some follow through with that. You definitely want to print out anything that's involved, home exercise programs, recommendations, strategies, things like that, making sure that they don't have any questions, that they can indeed do that home exercise program either independently or through the assist of a caregiver as well. When somebody is moving to our next level of care, sometimes we get to follow them if we're in a CCRC and we kind of see all those people, which is nice to see them go from a hip to home to you know, out in the community. Sometimes we don't have that ability. They go back into the community, we don't see them. But one of the nice things is to try to see if we can get a post-discharge check-in. In the SNF environment, that's a little easier, where we have quarterly screens, risk meetings, nursing referrals. CNAs will come and tell you if something's going on, so that's a little easier that way. Perhaps with the home health environment, I think they, at least the company I used to work for, did follow-up calls, check-in calls, satisfaction surveys, things like that, just to see how people were doing. Hopefully, if there's an issue with the PCP, or somebody's been given some training and things like that, going back to their doctor, checking in, seeing those things, checking, skin integrity, all that kind of stuff, as a way to, check in and make sure that that what you've prescribed and all the tricks and training that you've taught the caregivers are being followed. Again, how do we offload caregivers without adding to their stress? So we, see certain patients, we get them all ready to go, and we have all these wonderful suggestions and things to do. And so how do we get those people to do them without making that more stressful for them? Again, task breakdown and energy conservation kind of techniques, things that we do with our residents, we're going to do with the caregivers as well. Try to not make them overwhelmed with giving them everything at once. And when you are doing training as you're going along before a discharge home or before a discharge from a skilled services, you will have that time to thoroughly make sure that they understand what they're doing. If they have any questions, sometimes people are embarrassed that they don't understand things. They don't want to let you know they don't know things. So hopefully you'll be able to see, especially with the return demonstration, things that can be helpful and make sure it's a successful discharge. Behavior modifications. This is part 2, using some of the strategies from our mental health program. Validation, stress reduction, and sensory stim kind of things. When caregivers come into the SNF and that they're a 24-hour caregiver, or that they work full-time and then come home and care for a loved one, a lot of the times either social services or part of the rehab team will let them know, hey, your loved one is okay here. Take some time for yourself. This is your vacation. This is some time that you don't need to be here 24 hours a day. People, and there's cultural differences too. You have to expect a lot of, certain cultures feel horrible having to leave their loved one with someone who's not family, and giving them the, validating their feelings about that, making sure that they understand that this is their time too. And understanding that they're just as stressed out as the the loved one who's having issues as well. Teaching them ways or giving them information on possible support groups, things like that, stress reduction, yoga, the deep breathing, have them do it, the return demonstration again, have them do it with their resident, and everybody's all nice and relaxed and unstressed. Sensory stim kind of things as well. When you walk into a busy, activity area, TV's blasting, you've got, something on the music, there's, a resident having a hustle-puffle in the corner. That's a lot for even, just a regular employee, never mind someone who's already, having other deficits. So, teaching families and teaching the caregivers on how to reduce certain overt sensory items, loudness and things like that, but providing some other sensory things that are relaxing and that will help them reduce their stress. We do scents sometimes, scented hand lotions, doing those kind of things, just soft, easy lighting, just for those caregivers, not necessarily for the residents, because they need all those bright lights. Individualized education and empowerment. So that is tailoring the discharge plan to the resident and to those caregivers. You will find different caregivers have different needs. Some people are 24 hours, some people work, some people have their own children, so they're that sandwich generation. So being able to identify what their needs are and what will help them most is a very positive experience. When we have families that go through their discharge training, are leaving the building and say, hey, thank you so much for everything. It's going to be great to have mom home. It's going to, this one last try, it's going to be fabulous. So it's a lovely thing to be able to do with people. And the multiple learning modes too, with not adding stress. Again, people have different ways of learning things. I always, regardless of the method of instruction, I like to give a handout, because sometimes in the moment it's overwhelming to hear all of these things. They're just overwhelmed with the whole situation and having to be a caregiver and having to learn all these things. So having something to look back at, having resources that they can take some time later on to look at when they might have a quiet moment, giving them, again, things like printed HEP programs, suggestions, things like that will be very helpful as well. And SMART goals, care plans. What does it look like when we are writing kind of goals for caregiver training, and kind of, we don't call it like a burnout goal per se, but training all of these things for caregivers and residents will ease the burden of caregiving and make it less stressful for both parties. So for instance, physical therapy. Caregiver will demonstrate the ability to complete AFO application removal, including skin checks on 3 to 3 trials without verbal cues within 2 weeks. With speech, your return demonstration of compensatory swallow strategies for optimal safety. And then OT, again, will show understanding of utilizing adaptive equipment and energy conservation strategies for bathing with return demonstration within 2 weeks. And again, best to get the caregivers involved during the episode of care while they're doing those things, assess competency, and then modify the program based on the caregiver's comfort level. And by all means, if someone comes in with a fresh hip and they're maybe partial weight bearing, you can still do that education and training while they're at that partial weight bearing. That's not to say you're never going to do it again. So as that resident progresses through their recovery, you're going to keep doing the trainings and keep doing the caregiver education as they progress. So conversely, sometimes through the disease process, when somebody new comes into a system, you're going to train the caregiver on their level of abilities now. And then again, later on, we're going to try to preserve those abilities and then train them for how to keep that going and what to expect. So a lot of great things that can go on.
All right, thank you, Nikki. It's been a great discussion about, how do we define caregiver burnout, what kind of assessment tools we use, what are some of the strategies, how we can train them, what some of the resources are. So we just kind of wanted to take a moment and add a few resources that are at our disposal. I love the caption of this slide, which is therapists are lifelong caregivers. Think about us, what we do as paid or what I call as informal or unpaid caregivers. We provide services at our workplace. We help out in our home environment. So just kind of keeping all those options in mind, just know that most of the employers, if not all, have this employee assistance program. Do tap into that resource because it kind of guides all of us on what can we do if there is increased anxiety, if there is increased stress. Some of the resources, you can just kind of go to your HR person and have them maybe talk about what could be done and how it could be done. We listed some of our state organizations and national organizations that have the resources on the website. So do explore APTA, AOTA, and ASHA websites to see what kind of resources are listed. Peer mentor, we all are talking as peers on this call, we are presenting, but the material is all compiled by all of us, together, our experiences. So just kind of thinking about that peer-to-peer conversation. Are we reaching out to a friend, a guide, a coach, or a mentor? The PTO, paid time off, we all have the ability and the advantage and the privilege of using that. Do we plan it out throughout the year? Are we considering like a mental day off? Are we able to provide that work-life balance where we feel like, I know I'm going to be having a very busy week in 2 weeks. Can I plan something so maybe I take half a day off or a day off if there is provision, ability, and then my capacity to do that. I always kind of think about, plan it out for the entire year because, unplanned things will keep on happening throughout this time as well. Work-life balance, that is very important, having a structure, thinking about when is my start time, when is my end time, and kind of setting up those boundaries also. So if you are a leader, if you are a director of rehab, if you are in a leadership role, people are not calling you at 6 a.m. or 6 p.m. You got to make sure that you establish those boundaries and make sure people respect those boundaries for you. Take breaks, when you can, whether it's a quick 15-minute break or a lunch break, just kind of take advantage of some of those things. And then engage in meaningful activities. we all have, kind of thinking about personal and professional growth. What kind of things could be done? It could be just attending a seminar that just talks about some, stress relieving techniques, or it could be something that I want to become an LSVT, or I want to go into an advanced, some kind of a course. Think about what is your passion, whether it's a clinical passion or you just want to develop into a leadership role. Kind of consider all those activities so we continue to grow and we continue to provide that work-life balance. The next slide kind of, we just kind of wanted to touch base on some of the billing guidelines after we have talked about treatment strategies. How do we go about billing for caregiver training? So there are two components to that primarily, and then I'll touch base on a third one also. We all are familiar with caregiver training with the patient present. We try to kind of provide that training to the patient and the caregiver, and then we select the CPT code that is most closely associated on the training component. The other modification to that is caregiver training without the patient present. We'll go into that in the next slide just a little bit so everybody is familiar, or it's a refresher for all of you. There is a caregiver support code available effective the beginning of this year as of January 2024. So just kind of making sure that there is a provision for training provided to an unpaid caregiver. The last component of that is skill maintenance. Skill maintenance is an adjunct resource to patients when we feel like these services are of such complexity and sophistication in nature that they can only be provided by a skilled therapist or a skilled therapy assistant. We can offer skill maintenance. That way we are able to maintain the level of the individual. We prevent any kind of a decline, and then we can ensure these services are still skilled in nature. That kind of leads us into our last polling question. You can bill for caregiver training and education without the patient present. Is it true or is it false? So we'll give Shaila some time to kind of look at, how people are responding before we close the polling question. How are we doing, Shaila?
I am going to go ahead and close it out now. 56% of you said true and 44% said false.
Okay, so that would be a good thing to kind of move into our next slide. Nikki can go over, and then all of you, I think, would be on the correct answer, which is we can bill for when the patient is not present. And here are some of the ways that Nikki is going to go over.
Yes, something else new for us this year was the implementation of the Caregiver Training Services CPT codes. These are for training unpaid caregivers when the patient is not present. So there's 3 new codes to reflect these services. The first two, 97550 and 97551, are used to report training a single caregiver or multiple caregivers for the same patient. So for the 97550, they're both time-based codes. The 97550 is for the first 30 minutes of CTS or caregiver training services, and then every additional 15 minutes up to after that is 97551. In order to report at least 1 unit of the CTS, you need to bill at least 16 minutes of caregiver training, and you're never reporting more than 1 unit on a given day per discipline, and you can read some of those outlines as well. And then conversely, when you are training multiple caregivers for multiple patients, there's a code for 97552, and each patient would get 1 code billed to them as well for that. So that would be maybe in a multiple setting if you're doing, caregiver training on, a general thing for all of the patients per se. So wonderful to be able to do that. again. So because there's a lot of different patients that have, complex needs, patients with dementia, dialysis, people who have complicated healing fractures, who are very medically compromised, fragile, a lot of diseases and things. So sometimes they're not able to actively participate in the training. So this is a wonderful way to get around that. No, I shouldn't think get around that, but to be able to capture our services. And then the billing requirements and considerations, the caregiver training codes are not currently supported by telehealth. So that has to be live training with residents and caregivers. They must be part of the patient's therapy plan of care and relate to the therapy goals that you've set out for them. Somewhere in your documentation, you have to consent that the patient documented to have caregiver training done. It can be provided over multiple sessions as long as it's medically necessary. Definitely document what you're doing. Part of the Med B benefit, more so than the Med A, we can still use the training can still be done, and we can use the CTS codes. It's just not going to count towards the MDS minutes. So, again, please check with your providers, and perhaps maybe your intermediaries might have some different rules on that.
All right, so these are some of our resources and references that we use to create the presentation. But that really brings us to a close. I just really want to say thank you to everyone for joining. It has been a joy to be a part of this team and create this presentation. And I will open it up to any questions.
Shaila, are there any questions in the chat box? I can't see it.
The only thing that's really here is, hello, I was a caregiver for my mother until last October. Therefore, I'm familiar with palliative care and hospice care. Does Aegis have any positions related to patient advocacy, patient family education, family support staff, etc.? I've been an SLP for 30 years, but now rather provide patient advocacy in different environments, focusing on navigating considerations. I'm not really interested in conducting speech assessments and therapy at this time. I believe that you can always go to aegistherapies.com and you can find a list of all of our available positions there.
Yeah, forgot to mention that. Yeah, maybe to just for that last, it's kind of a little bit of a question and a story combined there, and to have that experience of being that caregiver through those different modes is really invaluable, right? But we do, really want to make sure that we're working with caregivers throughout that continuum and into life if needed. It is, a Medicare benefit of the residents if they need skilled services that they can access them. So just really being that advocate for your resident and their needs throughout their healthcare course is important. Any other questions that we could try to work through?
There is not.
Okay, well, we'll hang out for another minute or two and see if there's any additional items that pop up.
Thank you everyone for attending the course today.
Yeah, absolutely. Thank you.
All right, guys. Will we be getting the test emailed to us for CEU credit? Yes. If you are required to take a test, meaning OTs and CODAs, you will be getting an email tomorrow with that link for the test. Again, only OTs and CODAs are required by AOTA to pass this test in order to receive a certificate. You have to pass it within 1 week. And if you do not pass, you have to get in touch with me and I will give you a code to the second link.
Shyla, I'm not sure if you have already. Do you want to just put your contact in the chat just in case?
Sure.
Okay.
And I still see few people are still on the call. And if you are an OT or a CODA, I think the questions that we put together in that test, post-test, should be easy enough to pass. It was, all the questions were kind of included in the content we presented today. So I'm hoping everyone would be able to pass. If you don't, for any reason, just send out an email to Shyla, and then she will send you another link to go through the questions.
I do have a question here. Let's see. It says caregiver training code. Is it only for unpaid caregivers?
That is correct. You know, the paid or you know, if you are training a CNA or somebody who's directly involved in the care of that individual at the facility level, you would incorporate that into the training session. That caregiver training code is primarily for non-paid, unpaid caregivers.
Yep, I agree with that answer.
Do the billing codes have to be included in the initial eval, or can it be added during research?
It can be added during a recertification or an updated plan of care. You just want to make sure that there is a goal associated in that care plan that would really support that training and those services being delivered. Good questions.
Mm-hmm.
All right, guys, I think that is it. And with that, thank you for attending, and we will see you next time.
Thank you so much.
Sounds good. Bye-bye.